Good morning, and thank you so much for joining us for Tuesday Tea. We appreciate that you're here. So, I think that the briefest and best introduction that I can give is that I facilitate for at least a dozen EMDR foundational trainings every year. And every single year, we say, if you have any interest in neurobiology, you need to read this book. And that is your book, The Neurobiological Foundations for EMDR Practice. So, would you please introduce a little bit about your work and background? And then we'll get into some questions that will be appropriate for general therapists who might not have the clinical background and experience that you have.
For my background, I went to graduate school first to get my master's. And by the time I came out, I had learned some things about psychodynamic therapy, but mostly cognitive behavioral therapy. And I had been interning on a psych unit of a general hospital. And after that was my last year, I was hired. So I was working on a unit where basically something would happen in relationships and people decompensated. There were no psychotic patients because that wasn't allowed in a private hospital. So basically, everything had to do with some kind of borderline personality configuration, narcissistic personalities. And everything I had learned really wasn't helping. And so then I got involved in psychoanalytic training, relational psychoanalysis. And I was doing that. And 1989, a colleague of mine came to see me about something, and he brought me this paper. This was Francine Shapiro's EMD. She described the protocol. If you do this and this, but the caveat was this was just for type 1 post-traumatic stress disorder. In other words, you treat the child right after the child is traumatized, or you treat an adult, but the trauma itself is fully adult onset. And basically, the paper read, if you do all these procedures, your patient will be fine. And I thought, this is a little strange. And also, typical East Coast, whatever, arrogance, prejudice. I remember in my mind thinking, why would I pay attention to anything published out of Palo Alto? Stupid, but that's the way we thought back then. And then for some reason, I didn't throw the paper away, I put it away. And I had been working with somebody with a type 1 PTSD, was using hypnosis, and it had gone pretty well. She was in treatment for about 8 months. And she came in for her last session, and basically she had been robbed again and pistol whipped. She worked for a place that didn't invest in security. And so she was going to quit. And she had worked herself up from slinging burgers, and she was one step away from corporate for the company that owned where she worked. And I remember saying to her, let me write you a letter that you don't have to go to work. Come in on whatever it was, Thursday, and I'm going to be sitting here with a clipboard and doing a whole bunch of strange things. And let's just see what happens. And she came in, just full on PTSD symptoms. And I just started to do this thing, waving my hands back and forth. And 50, 60 minutes later, she was fine. And she came back for a follow-up and she said, I'm fine. And I remember my father was a psychiatrist, and I called him up and I said, I just found this technique that cures type 1 PTSD in 90 minutes. My father said, yeah, okay, it's pretty cool. Do it 10 more times and call me again. And so I did. And then I called him again. January of 1990. So I had taught myself EMD, and so I was using it. Then the same colleague came to see me about 3 years later about something, and he showed me a brochure. EMD had now become EMDR. And so at this point, I figured, okay, let me get formally trained. Let me meet Francine Shapiro. It was like there's a new Freud in town. And I got formally trained. And I know now from being on the faculty of the Institute, they would look for people who could catch on really fast. Well, I wasn't necessarily catching on really fast because I was any more brilliant than anybody else. But if you've practiced EMD for 3 years, learning EMDR was actually much simpler. So basically somebody told me if I was interested in teaching, in a couple of years apply. And I applied to the Institute. And then we all began to try to use it in more complex situations. Anything from one end of the spectrum to just neurosis, which is basically, I think, the human condition. That's why most people don't walk around saying we're all neurotic. If you're not neurotic, you're in trouble. But by now, people talk about everybody has issues. So that was one extreme. And then at the other extreme, I got more and more involved with complex PTSD, which today in the DSM is still all the dissociative disorders and such. And there, of course, it stopped being this great miracle. And we all had to learn and integrate other techniques into it. We began to work with ego state work. I tried to integrate psychoanalytic techniques into it. Began to realize, just from a clinical point of view, to focus on the body more and more. And that's my background. The other piece that brings me to maybe what we're talking about is, as an undergraduate, my background was in developmental psychology, and I had a background in neuroscience that came from being a zoology minor. So once you were into that, if you knew enough people, you could then take a lot of neuroscience courses and leave the other stuff out. So that was always in me. And in the middle 90s, I began to really try to figure out, how does this thing work? Just for type 1 PTSD. And then just began to study more and more neuroscience, and it brought me to all the stuff I've been doing until recently. So I guess that's my background.
I love that. Yeah. And it strikes me that you describe, just because school was quite a long time ago for me. So when I read a book that says, oh, we have the neural underpinnings of, we're going to talk about the neural underpinnings of consciousness, it strikes me because we knew so little then. And I feel like we're learning just more and more every year. So I would love to ask about encoding, interpreting, and storing knowledge and how that's related. First of all, how it works, as much as we know, and then how this is related to EMDR.
Just so I understand the question, in other words, you're asking a question in a sense, how does memory work?
Yeah.
Okay. All right. It's a very good question in itself. And it's also become one of the, I don't know, controversies in EMDR, actually in all therapies. But okay, memory. First, because one of the phrases in AIP is that the memory is dysfunctionally stored. Now, that is actually the only incorrect thing in AIP, because what we've learned is, first of all, memories are not stored. There isn't any place in the brain, like there is in a computer, where memories are filed away. What actually happens, so what should be in AIP, but Francine wouldn't change it, is that the memory is actually dysfunctionally linked. So backing up a little, let's look at learning and memory. So when we experience something, basically we experience first in a sensorial manner. It comes into our eyes, we smell it, we taste it, we hear it. Sure, I'm missing something, but it begins as sensory information. And then what ends up happening is that, and so you have all of these primary sensory centers begin to fire, ensembles of neurons, circuits. Then what also happens is that what also gets activated, so the sensory stuff is what's called exteroceptive information. And then, but as we experience it, things are also subjectively activated. So in the part of the brain where we have interoceptive information, basically our emotional centers, our association areas, somatosensory areas also get activated. And so they fire. Now, what happens is there's an area in the limbic system called the hippocampus. And so now you have all these ensembles firing. And the hippocampus will create sort of a map of all the things that were activated during this one experience. And that map basically lays dormant and encrypted. and it's called an engram in neuroscience. And so all of these things fire. So you have objective information, you have all of these areas, primary visual areas, then you have the cortices involved. So the visual cortex, the audio cortex, the somatosensory cortex, associational cortices. So they're all firing. And as they're firing, the experience gets encoded. So that's how we go from, when you talk about consciousness, going from sensation to perception to learning to memory to emotion to somatosensory integration. What's left? Language and motor function. When the experience is over, so let's say I wave my hands now, all of this whole ensemble gets activated if you're watching it in your brain. Then when it's over, all of those activations deactivate. So there's still no memory stored. If you try to remember that particular memory, what ends up happening is about that engram that's encrypted in the hippocampal area becomes activated. So you have, it's like a map. And about 80% of what happened when the memory was encoded gets reactivated. Why 80%? At this point, your visual centers or your olfactory centers, your smell, well, those don't get activated because you're not smelling something now. But your visual cortices get activated, your audio cortices get activated. If the memory had to do with smell, your olfactory cortex will get activated. So it's about 80% of it gets reactivated. And then you have the experience, or you experience the phenomenon of recalling something. Again, all of that information is not stored in the brain. So to create the memory, the information has to be linked, and then the information has to be bound together electrochemically. And then to remember it, the same thing has to happen with a whole bunch of other mechanisms also working. So in that sense, again, memories are not stored. Memory is not a noun. I have a colleague, Amy Conklin, passed away recently. She was listening to this talk that I was giving, and then she walked up to me, brilliant psychiatrist, and she said, so memory is not a noun, memory is actually a verb. So basically, when it comes to memory, that's how it gets created, and that's how it, in a sense, can be remembered. There are a few other processes involved that have to do with linkage of information and how you bind it together and synchronize it. But ostensibly, that's how we learn and that's how we remember.
That's really helpful. There is something that gets talked about a lot in that arena when we're in EMDR trainings, which is neurons that fire together, wire together. And I was hoping you could speak a bit to that.
Okay. So this takes us back to a Canadian psychologist, Donald Hebb, postulated a number of things about neuroplasticity. In other words, what he had realized is that very little of the brain is really hardwired. The only areas in the brain that are hardwired are the areas that directly mediate our physiology. Those things have to be preset maps, and they have to be exactly the same. If you think about it in terms of medicine, if your body temperature goes up by a half a degree, you already don't feel well. If it goes up by a degree, you're already ill with something like a flu, right? So those areas, there's no plasticity. In other words, they can't change. The same thing is also true of our perceptual systems to some degree. On some level, we all have to agree on what red looks like, green looks like, yellow looks like, a few other colors, because they have to do with nature, and all species have to be able to do that. But other than that, there are a few other things. Most of the brain is not hardwired. It's actually, it's neuroplastic is the term. And if we want to use kind of something that we're all involved with in terms of our digital life, so most of the brain is a kind of a Wi-Fi Bluetooth system. So that's one of the things to keep in mind. It's funny, I lost the point of the original question.
Neurons that fire
Right,
together,
right.
wire together.
So what Hebb said is that neuronal assemblies that tend to fire simultaneously for long enough become associated in such a way that at some point the firing of one will stimulate the firing of the other. Now, that's all very nice and esoteric, and clinicians will often say, that's wonderful. What am I supposed to do with that? One of the things that it speaks to is in childhood, for instance, if whether parents regulate their children, at least until the age when children can regulate themselves or not, what we've learned is that states of mind, if carried on long enough, become traits. All right. So basically, it all gets wired in. And then in adult life, you can have one stimulus, and then all of a sudden you have another reaction like you did when you were a child. So those are the original words, that when systems of neurons fire together for a certain amount of time, they become associated, that at some point, the firing of one will initiate the firing of the other. So this is from the 1940s. Now, Carla Schatz, who was a teacher at Harvard for a while and then at Stanford, became famous for the way she used to succinctly express theories. So when it came to what we're just talking about, Carla Schatz said, cells that fire together wire together. And that's where that phrase came. And then somebody turned it into neurons that fire together. What she also said, which is when that doesn't happen in terms of different kinds of pathology, she also said neurons that fail to sync fail to link. Now, the reason I bring that up is that if you go to AIP, for instance, and this has to do with how we teach and how we practice, if the memory is dysfunctionally stored, then basically your paradigm, which in this case is EMDR, states that the target of EMDR should be the memory. Now, in the beginning, type 1 PTSD, soldiers from Vietnam, car accidents, assaults, of course, the memory was the target. But what ended up happening is that at some point, people used to call and used to say, I don't understand, if my patient basically was at one extreme, physically and sexually abused from the time he and she were 5 until they were 18, where am I supposed to get to the memories, and how do I get to all the memories? And the same thing, we used to get these questions from people who just worked with neurotic people who said, what am I supposed to use for memories? One parent was a little bit too obsessive. The other one was a little bit too hysterical, but things were pretty much normal. What kind of memories am I supposed to process? Now, back then, we were supervisors. The only reasons we were experts is that basically in the Valley of the Blind, the one-eyed man is king. We knew something, the rest of the world knew nothing, and so everybody was calling us. And I remember when they used to ask that question, this is before having some of this neural understanding, many of us said to them, maybe what you should do is focus on core beliefs, which in EMDR parlance would be the negative cognitions. We knew the same thing from psychoanalysis. You don't focus on memory, you focus on what are called self and object representations. How do I see myself, and how do I see others? Which is similar to EMDR's negative cognitions or cognitive behavioral therapy's use of schemas. And what we found was when we said to them, make the target the core belief, and then basically call us up and tell us what happens. And they found that they were able to work. So basically, what all of this tells us, in a sense, is that if memories, for instance, are dysfunctionally linked, then there really isn't any point in working with the memories themselves, but working with what the patient brings. Because now you are dealing with, on some level, neurons that fire together, wire together. Because basically, why are they here? They're here because the past is present, or one great title of a book, or another great title, because they can't get past their past. Why is that? And it's because of when all of these dysfunctional things, even whether they were a mild level or a severe level, when all of that got wired into the brain, and now you're dealing with the adult or even the child, that basically all it takes is one stimulus. Somebody could just give you a dirty look. A boss can just give you some attitude. And now all the other neurons begin to fire. And now you feel like a 5-year-old. In a sense, you're living in the present as if the past is still present. So that's one of that particular concept is one of the earlier concepts that explains that. And so it has a lot to do, even when you look at EMDR treatment, that if it's really the memory is dysfunctionally stored, then you focus on it. But if the memory is dysfunctionally linked, then in a sense, you need to work with the outcome of that, which is how the person perceives themselves. To give you another example. So somebody comes into treatment and you ask them, what brings you here? I have this feeling that I'm bad, that I'm broken, I don't deserve anything good, everything is my fault, I'm damaged. Then you take a history, and now they're telling you about parents who basically were always angry and always said to them, you're nothing, you'll never amount to anything. So on some level, clinicians will conceptualize where they're having a problem with memory here. So patient comes into treatment, you do whatever preparation you need to do, and then you begin to do EMDR. And at some point, it doesn't take that long, before a patient will sit there, and this is a very common thing that we hear. Okay, I understand right now. My parents were traumatized when they grew up. They were dysfunctional. No child should be told something like that. Yes, the pathology was in my parents, and I understand that. So you see, at this point, memory has been sorted out. But then the person will say, but why do I still feel like I'm damaged and I'm bad? The reason for that is that the memory is not functionally linked. So when they talk to you, if you had this conversation and they're in an fMRI with the newest resolution, and because neuroimaging started, we used to look at all these dots, red dots and blue dots and green dots, and we would just see what areas were activated. But then eventually they created neural conductivity paradigms, where now if a patient remembered something or whatever they were focusing on, you can see circuits now in the fMRI. And we have other kinds of imaging. Basically, what's happening is in this conversation, the patient says to you, okay, I remember now, I can see it. My parents were dysfunctional and they caused me to believe that I was. All of this is firing. There's all kinds of linkages that are firing. But then the person says, but why do I still feel as bad as I did when I first came in here, except that I have this insight? That's another thing that's firing. But if we looked, we understood linkage and binding is that this information doesn't link together. So I am bad. My parents told me I was bad. There's a whole bunch of ensembles are firing. And then there is, and I understand that the problem was really theirs and not mine. Now you have another bunch of ensembles firing. And then there is, but why do I still feel as bad? So all of that information does not link and sync together. And so that's where a patient says, I understand the problem, but I still feel this way. And that's really the implication of understanding that, again, memory is not dysfunctionally stored, but dysfunctionally linked. And linkage and binding is really the basis of all of consciousness, and therefore all the basis of disorders of consciousness.
That's really helpful in understanding just what a lot of our clients are going through and what we go through as human beings. I have a question about a really specific part of the brain that we gloss over, but is really important when we're talking about trauma and trauma memories and the reactions and responses that people have. So I have a colleague who describes the amygdala as the smoke alarm. And I'm wondering if you could speak a little bit to Oh, actually, I made nerdy notes in your book, but sensory signals from the nose are routed directly to the amygdala, bypassing the thalamus. And that really struck me because earlier you were sharing with us about the different senses, and I was wondering why the olfactory is potentially different than other senses, and what that means for the amygdala and the thalamus and all of that good stuff.
Okay. Except for smell, everything enters the brain into the thalamus because the thalamus and the thalamocortical mantle around it is basically the essence of consciousness. Now, for some reason, let's begin with, which is semi-rhetorical, smell goes directly to the amygdala. Why is that? The best answer that anybody has come up with is if you look at most species of animals, for the most part, they process the most amount of information through smell. Not so of humans, all right? But almost all other species, smell is really one of the most important senses, much more than the eyes, because they can smell things way before they can see things and way before they can hear things. So somehow nature, its wisdom, decided to send that particular pathway directly to the amygdala. So again, that speaks to species across the spectrum. So that's one piece. I don't know if that answers your question or there's more that you want in terms of getting to our species.
I think that's a great shift in my understanding for it. I guess that the other piece that I would add is how does the amygdala shift the physical response in people who might be having a traumatic event? Or I'm thinking of, for example, I can call it something more eloquent than gut feeling, but when we just have that sense that something is wrong, is that attached at all to the amygdala and the responses that something is saying to us, warning, danger, be prepared?
It's a good question given on some level what has been taught. So in the 90s, all of a sudden we began to learn about the amygdala. Before that, everybody who studied anatomy knew something about it. But in the 90s, Professor Joseph Ledoux, he had been at Cornell and then he came to NYU Neuroscience Center. And in the 90s, he did a lot of research and publication. And the 90s were full of all of us talking about the amygdala. This was like the core of emotion, and the amygdala interacted with the hippocampus. There's a lot of information about that. In some ways, some of that has become outdated. Not because it was wrong, but what was incorrect was that the center of what you just described, emotion, the visceral response to emotion, allegedly should be mediated by the amygdala. What we've learned since then is that it's not. That basically the core of consciousness is in the brainstem itself. So again, knowledge follows knowledge. So basically, if we begin, pain and pleasure basically are mediated in the brainstem. We know that now. So we're talking about medulla oblongata and the pons. What we were initially taught was that pain and pleasure was mediated in the insulas, which are the bottom of the cortex. And then the insulas connected through the amygdala. But what we've learned since then is if there's any kind of an obliteration of the insulas, pain and pleasure doesn't go away. And that shocked everybody. And then as neuroimaging became more prominent, some really top neurologists like Antonio Damasio began to study that. And what we learned again was that pain and pleasure was mediated in the brainstem. I'll skip all the other fancy terms because it can be convoluted. And again, we found out that if you destroy the insulas, you can still feel pain and pleasure. And then we learned that these two areas, I'll say them and people can just forget them. It's the nucleus tractus solitarius and the parabrachial nucleus. They're in the brainstem itself. So this is the basement of the brain. And then just above that, still below the cortex, is an area really badly named the midbrain, where you have the paraaqueductal gray and the inferior and superior colliculi. And they take that information and mix it together. And that's where raw emotion is generated. And that is where today, at the cutting edge of neuroscience, that's where consciousness is created. Basic consciousness. I'm not talking about reflective consciousness, sitting around wondering what is the meaning of life. But basic consciousness is mediated in the brainstem and the midbrain. And right now, separating the two is just nerding out. They're basically the brainstem. Or if you want to say, okay, it's the brainstem and the midbrain, but it's all subcortical. That's one thing that we realized. And everybody was like, wow. And then they argued back and forth. And then finally, I think it was Damasio and a few others who said, and they looked at hydroencephaly. Now, in hydroencephaly, the child, is still a uterus, undergoes a massive stroke, which destroys the neocortex, the cortex below, like the anterior cingulate cortex. It destroys the limbic cortex, and it destroys the insulas. In other words, there is nothing left but a brainstem in these children. The rest of their skull is filled with water, which is why it's called hydroencephaly. So according to all these theories, these kids should be vegetables. But if you look at them, when they're happy, you can see they express it. They smile, they laugh. When they're unhappy, they fuss, they arch their backs. That is primary consciousness. You're feeling the world, and it either pleases you or it displeases you, and you're able to express it. That is consciousness, basic consciousness. You can't define consciousness based on Homo sapiens, because we have learned for too many other subjects, which to get into here, if you're explaining anything in neural function and you can't show how it relates to other species, at least going down to mammals. Below mammals is another story, but at least to the lowest mammals, because mammals are the first species that attaches. They attach to themselves, they attach to their offspring. Basically, now we became aware that consciousness is in the brainstem. So initially it was like, okay, this is cool. What do we do with that? Then what we began to find out is that we began to learn about the vagus nerve. This is Steve Porges's work. Now, what Steve Porges was looking at is the vagus, which is the 10th cranial nerve, which is located in the brain's basement in the medulla, and it has two branches. One is the dorsal vagus, which basically mediates what we know as dissociation. It's immobilized freeze. And then we have the ventral vagus, so now let's bring it to human beings. So at birth, parts of the ventral vagus are there. And what the ventral vagus does is it mediates social engagement. It mediates the muscles in the eyes, the muscles in the middle ear, the muscles in the face, the pharynx. It mediates the child's ability to express themselves, even at that primitive level, but facially, in terms of social engagement and expression. So far, until the age of 3.5, the child cannot affectively self-regulate. That's why the child needs the parents. And people used to write about it, Alan Shore particularly. So the child needs you to use the parent's orbitofrontal cortex to regulate theirs. But then, so again, remember, there's this all of a sudden one big piece of knowledge that consciousness is mediated in the brainstem. Then we find out that around the age of 3.5, the ventral vagus then finally becomes fully myelinated and then connects itself to the orbitofrontal. And now the child can self-regulate. Now that by itself also, people said, okay, great. So this comes on, but it allows the orbitofrontal to do regulation. But that didn't sync with the fact if consciousness is mediated in the brainstem and affective regulation is actually not possible until the bottom of the brainstem, the ventral vagus, becomes fully myelinated. This is basically way too much of a coincidence for us to blow this off. And then we began to learn from the works of Ian McGilchrist, who basically surveyed a whole lot of research on the divided brain. What is the difference between the left hemisphere and the right hemisphere? And there, he brought out this vast amount of information that basically the left hemisphere is basically only useful for learning things like mathematics and science, some procedural kind of memories, grammar, and things like that. But everything else, the human emotional domain, the human social domain, all takes place in the right hemisphere. And we can get into that. That caused a complete paradigm shift in how treatment should be done. Because we had learned with EMDR that basically EMDR was bottom-up processing, which meant you don't think, you just notice. But then, this is going back to the 90s, and we were told stay out of the way. But as soon as things stopped working, then it's time to get in the way. And then what do? We went to cognitive interweaves, which now is a top-down process. And the point is, cognitive interweaves don't fix everything. I don't know that they fix much of anything. They don't fix anything. But we now understand basically that can't really work because the right hemisphere has multiple connections to the left hemisphere. The left hemisphere has one basic route that goes to the right hemisphere. So that's why basically you can sit there and get cognitive about whatever you want, whether it's cognitive counseling, cognitive interweaves. The brain is not meant to work that way. For simple problems, it can. But you could do cognitive interweaves with complex PTSD until the sun comes up and goes down again. It's not going to fix anything. And we now understand that. And this has caused this complete paradigm shift, which is, wait a minute, consciousness is mediated in the brainstem, affective regulation is mediated in the brainstem. Then what are we doing fussing around with the left hemisphere? So the knowledge has basically come out that all therapies, EMDR certainly, but all therapies, there has to be a paradigm shift, basically away from the central nervous system, all of this stuff up here, to the primacy of the autonomic nervous system, which is the midbrain, brainstem, and the peripheral nervous system, and away from left hemispheric cognitions to right hemispheric cognitions. And then people would say, okay, that's fine. I can see your logic and reasoning here. The left hemisphere has language. What's the language of the right hemisphere? And this came out of the work, again, that Ian McGilchrist highlighted and published all the research on, that basically the right hemisphere does have a language. It's a language of images. Images the way most people define them, but most of all, somatosensory images, the body. Now, in the past, obviously, there were body workers before we knew anything, but we all argued. The body workers said the cognitive people were dumb. Everybody argued with everybody because all of psychotherapy was a social science. But now you have data that tells you need to use the right hemisphere to fix the right hemisphere. The language of the right hemisphere is images, particularly somatosensory images. And if you know from the studies about consciousness, vagal system, the polyvagal system, that everything now directs you away from the central nervous system into the autonomic nervous system, again, which is the brainstem and the peripheral nervous system in the body. And this is where we are today. And so it's not amygdala. The amygdala does things, but the amygdala is responding to the brainstem and the midbrain. So we now understand if you want to make permanent changes, in other words, permanent trait change, to change state change into trait change, you have to change structures, work on the plasticity of the brainstem itself. And in order to do that, and the other parts of the right hemisphere, then what you have to do is to deal with imagery, deal with the body, and then also understand that the memory is not dysfunctionally stored, but it's dysfunctionally linked. So that is the paradigm shift. It's a mouthful.
I love that, and I also love this. I think in dealing with adult learners, I love that we should not learn something and end our learning. That there's always new information that we need to integrate into our practices and into our knowledge base so that we can help our clients. That's amazing.
Yeah. And today you'll see it. Initially, some of us began to write about it. Now you have a whole new generation that's out there who are writing and wowing everybody. And they've even started to brand this. Someone like Rebecca Case, she basically publishes all of this as polyvagally informed EMDR. So yeah, it's changing the way we work. And I don't know, at least I'll be generous. Half the EMDR world is still practicing like it's 1995. And hopefully the other half is picking up on some of this, and it's changing the way it's worked. It's even changed psychoanalysis, all this knowledge, which now at the cutting edge is referred to as neuropsychoanalysis. It's not, let's try to understand what's happening so we can change. There's nothing to understand.
I love this. So for somebody like me who is open and willing to learn new stuff, what should be on my bookshelf? And I'm talking entry levels. So there's probably two levels, the people who have more of a scientific research base and people who are coming to it strictly from a counseling perspective who might not have all of the psychiatric experience that you have shared with us.
In other words, what should they read?
Yeah, I want to. So at the end of every Tuesday tea, I typically am hitting the buy button on a website because I'm saying, oh, I have to read this to stay up on my game. And you have just mentioned so many different people who have contributed to the field. But what would be a go-to? Because I know that a lot of the trainees who we have can sometimes be overwhelmed by the parts that they don't necessarily have a good grasp on coming in. So what would you suggest for that kind of practitioner who's coming in, they want to do a good job in EMDR, they want to know the neurobiology, but they don't necessarily have a great place to start?
Well, so there's two ways to answer this question. One way, yes, you need to read certain people. You need to read Alan Shore. You need to read Bessel van der Kolk. You need to read Antonio Damasio, Rodolfo Inas. That's one way to do it. Another way to do it, although it sounds like I'm trying to sell something. When I was approached by Springer Publishing, first they said, we want you to write something, a book. Okay, what do you want? And they said, can you write a book that becomes a kind of a primer that brings in all the people that you find that have influenced your way of thinking based on previous things I've written? And I found out that they used to run around listening to all of our lectures and stuff. So I can give a list of books and they're wonderful and go read them. Or I can basically say, you can use my book for a primer because basically in my book, I try to introduce all of this, then go back to how does a single cell work? Then how do cells talk to each other? Then how are systems of cells formed? How do they talk to each other? Then I go into consciousness. What is it? How does it work? How do you go from sensation to perception to cognition to learning to memory to emotions, somatosensory integration, language and motor functioning? So what I did is step by step get into that, then look at consciousness themselves, then look at what really is when you talked about neurons that fire together and all of that. How does that work? Okay. Now, to me, that was important for two reasons. For me to nerd out about it, that was for me. I thought it was important to see if AIP is the basis of how we practice, how does it match up to what we know neuroscientifically? which amazed me that 90% of it stands up except for that one statement. And then I tried to then show what the application of that is, or the implication of that is for the work that we do. And I know for me, for instance, when I was starting to get into this, I didn't know where to start. I happened to know Bessel van der Kolk, who was a mentor to me, and I said to him, all right, I'm all in, but where do I go? I said to him, I'm already reading everything you're writing. Where now? So he said, you go to Alan Shore. Because what Alan Shore does is Alan Shore researches the research. And Shore will then take you in 100 different directions. So I did that. And then Bessel's writing took me into academic neurology and things. So they were the primers for me. But again, I had the background where I already had the anatomy and neuroscience background to pick up on this. The other point of the book, which Springer said to me, was if you make a statement when you're writing for someone like Bessel van der Kolk or Alan Shore, that's fine. And that'll take you 2 or 3 sentences. But there better be 4 pages to explain what you just said. In other words, that the book should be designed for any clinician who knows nothing about neuroscience. So again, at the risk of sounding like I'm trying to sell something, my book can be a primer, and it will then take, those references will then take you everywhere else.
For what it's worth, we recommend this book in every single cohort that we train, and we train a lot. What I say to people is that you're probably only going to be able, I've been reading this book for years, right? So again, this is the Neurobiological Foundations for EMDR Practice. And what I'll share with people is that you're probably only going to be reading a couple of pages at a time. It is a lot to digest, but it is worth the focus and the energy because I think that it improves our practice.
Yeah. And I think the other book, which is also a kind of a primer in a way, is Bessel van der Kolk's The Body Keeps the Score. That began as his most famous paper. And then it began as a chapter in a book that he edited, and then it finally became his own book. But it's when I go through that, I remember it was published as I was writing the second edition of my book, and going through that, it was like in some way I thought I knew what his thoughts were on things, but his book also puts it together as a kind of a primer, and where he also tells you, okay, this and this is happening, this is important, and please follow this up with the primary source,
I love that. I am so grateful that you have taken part of your day to just help our community understand the importance of this work. We greatly appreciate you, and we hope to have you back soon.
I look forward to it.
Thank you.